Hi, you've reached the voicemail of Hannah Brett with Connect Call. Just leave a message and I'll get back to you as soon as I can. Thanks.
1 for more options.
Hey Hannah, you don't know me, but I now know you because I've been tuning in to Connect Call. I was on a flight recently and I needed to download a podcast or two to get me through, and thanks to Connect Call, it got me through that flight. I also didn't mean to sound corny, but I digress. Anyway, I really enjoyed Connect Call, especially liked the episode on your depression. I really could connect and tried a lot of different treatments and antidepressants and TMS and you name it. But there's a lot of buzz around the psychedelics and what's going on with depression and PTSD, and I feel like it's still so taboo, although I know who to talk to, and I have a lot of questions.
Hi, this is Hannah Brett with another episode of Connect Call, where I often say I do not have a clinical background, but I do have a PhD in picking up the phone for families in crisis, which many know I've done for I think 20 years, including our guest, Jonathan Lowe, AKA what I used to call him at my old job, J Lowe. For those of you that have seen this beautiful face before, it's because he has been a guest on this show before. And in the 3 months that we've been doing Connect Call, there have been guests that have been requested back, and you have been one of the chosen ones. And so I'm just really happy to have Jonathan here. A big reason, and I always stress this, and why I wanted to do Connect Call was not only to give these tangible resources in real time about real situations to families, but also really talk about the spectrum of treatment that is going on. Working in the quote unquote treatment industry or the helping field, one of the frustrations I often find is a lot of times people, I hate to say it, do not move with science. And so because of that, when it comes to mental health treatment or it comes to addiction treatment, we will find the tried and true treatments that everyone feels safe with, whether it's antidepressants, whether it's just talk therapy, all these different things. But, when we start talking about, which has been going on for years, by the way, ketamine treatment, like we had discussed before, or now even more diving into the treatment of psychedelics for PTSD and trauma. A lot of people have a lot of opinions, but don't have a lot of information. And that's why I wanted to bring Jonathan back on the show. Personally, professionally, I have also stressed this, Jonathan, and welcome back. Well, let me read your bio first. It's very important, shall we? Jonathan Lowe is a doctoral-level psychiatric nurse practitioner graduating from the University of Pennsylvania in 2007. He has completed advanced training through Integrative Psychiatric Institute in the use of psychedelic medicines, including ketamine. And he currently works in North Lake Tahoe area, California, starting the area's first Spravato clinic, which is amazing. So, Jonathan, thank you again for being here. There's no one better in my eyes that could really break all this down for viewers and listeners. And why, again, I stress why this is so important for me, especially personally, as someone who has really struggled with this treatment-resistant depression I've always had. I, was someone who got sober old school, did the 12 steps, and, took my antidepressants, but really was scared to try anything outside that box until it got to a point where this life I was building for myself wasn't really working because I wasn't open to the latest and greatest in treatment, right? And as soon as that happened, it was off to the races in a great way. Like I have said before, the infusions have helped me with ketamine, with my depression, but now I'm really interested in more of what's going on with psychedelics. And I guess just to start off, when we hear the word psychedelic, what substances are we actually talking about? What are people thinking we are talking about? And what, by the way, are showing the most promise when we're talking about psychedelics for PTSD, trauma, depression, and anxiety?
Yeah, so
That's a mouthful.
psychedelics are, kind of will alter our state of consciousness, right? Often leading to things like altered perceptions in reality. Some psychedelics might produce visual hallucinations. Some psychedelics might produce auditory hallucinations. Many psychedelics will cause this dissociation, kind of loss of physical self, sense of time
Right.
at particular doses, right? This is all dose dependent. And I think when most people hear the word psychedelic, I think that they think of more traditional psychedelics. Traditional psychedelics would be ones that are primarily focused on what are called 5-HT2A receptors. These are serotonin receptors. And when we activate, there's a lot of these receptor sites in visual centers of our brain, auditory centers of our brain. So when we take large doses of these types of drugs, that's what kind of produces the hallucinations that people have, or the altered states of consciousness in those two specific areas. And examples might be psilocybin, or what people call magic mushrooms, DMT, which is a naturally occurring psychedelic, other naturally naturally occurring psychedelics, whether it's ibogaine or mescaline. And then you have synthesized kind of in that same category of classic, like LSD. But I think most people think LSD and psilocybin when I talk to them about psychedelics. And then broader, right? So those would be classic, and they would also be categorized as hallucinogens, right? And then for just to simplify things, you kind of have a category of hallucinogens. You have empathics, which is MDMA, or what some people call ecstasy, right, on the street. So you have MDMA, and then you have dissociatives, and that's where ketamine and S-ketamine, which is brand name Spravato, they land in that category.
So I'm going off script right now. So because here's where I find it really frustrating, and I've said this, I think, in the ketamine infusion episode, like colleagues that I work with they're like, yo, how is your K-hole? Or when we start talking about treatment with psychedelics, they think you're going to start tripping, or it's going to be like acid, or like, it's like the psychedelics we would take as kids at macro major levels to really do that, right? Where we tripped or committed for long periods of time, under the influence of. And I guess what's been so maddening to me is, and maybe you can explain this better, is the dosing of what we're talking about is so minute. And and maybe you can explain how scientists kind of figured out how the psychedelics were able to do certain things that the other drugs were not doing.
Yeah, so
if you're able
psychedelics, so broadly speaking, like one of the benefits or a couple of the benefits of psychedelic medicine that we've seen in the brain is an increase in a neurotransmitter called glutamate, which is the number one restorative, reparative, excitatory neurotransmitter in our head. And if we can get that to activate, right, that speeds up new neuronal connections, strengthens axons and dendrites, kind of helps the brain to heal. Oftentimes in severe depression, we see what's called cellular apoptosis, or these areas of the brain where the neurons have kind of died, right? Or they're not working anymore because they've been exhausted. And getting that back, right, is important. So that neuroplasticity is a big piece of all of these psychedelic treatments, as well as that kind of glutamate burst that helps that along. And then there's this other part of some psychedelics helping with what's called the default motor network. A default motor network in regions of the brain that are involved in like self-reflection, rumination of thoughts, maintaining a self, an identity of self. Right. And we've seen some remarkable improvements in that default motor network with psychedelics that, again, we just haven't seen with traditional antidepressants. There's always been a theory that many traditional antidepressants may not function for many patients the way we think that they are. So, for example, an SSRI, right, we're often told 3 to 6 weeks by a provider. You start this drug every day and you kind of have to wait. And that waiting actually may be due to a downstream effect on glutamate. It can be miserable, right? And that effect downstream actually may be involving glutamate, right? because if it was just pure serotonin reuptake and inhibiting the reuptake of serotonin, then we should see results within maybe even the first few doses. And certainly there are some patients that I have that have that major shift or that turnaround after starting an antidepressant. But
Right.
as we know, many patients, at least a third of patients, will try multiple antidepressants and never achieve what we call a response, and a response meaning a 50% reduction in their symptoms is kind of the marker for success. And once we have tried a couple of antidepressants and failed to respond to them, the likelihood that we're going to respond to any antidepressant tried after those first two is
Right.
very, very low. And so it's really important that we have options for
Right.
patients,
No,
especially in this category.
it's funny. I was talking to a young adult male the other day who, again, he called me because his mother and I are friends. He knows I don't have a clinical background. I often say to anybody I speak to, I believe my struggle has been real and hard a lot of times, or has in the past, so that I could hopefully answer questions so suffering wasn't as hard for others. And I remember this is a young man who has tried a number of antidepressants, and he had questions about the ketamine infusions just because he was going to be assessed, and he was really scared about how this whole process works. And the one thing I did say to him is that, again, this was my personal experience, and I have also, I under the guise of I have tried, the psilocybin trials and all of that. And I will say the difference for me has been when I have sat in front of, um, you know, any psychiatrist or doctor who's prescribing me my depressive, they'll say, in 4 to 6 weeks, you'll hopefully feel this shift, right? And I'm like tracking my moods. I'm like a really good patient. I'll track my moods.
Yeah.
I'll do everything. I'll even get some of those black box symptoms and try a different drug. But I have yet to feel that shift typically. I mean, it's very hard. And so, again, what I have found and I stress this to this young man, I think, and this is, we're going to go into the next question about misconceptions. I think this misconception that I'm, as someone who has been sober for 23 years, that I'm getting high, right? And, and I'll say I'll get higher from a cigarette most of the time, from actually even doing any of these treatments, because there's such a small dose that, and, whether it's the infusion or when I've done a psilocybin trial or anything like that, the dosing is so small that it's really not what people think it is. And so why I again wanted to do an episode on this and talk about this more is also just for all those men and women out there who are in recovery, who are sober, and there really isn't sometimes a place for us to talk about this stuff without getting shamed about it. And I mean, I know that psilocybin is going to be only the way of the future, simply because I read the other day also, what is it? The pharmaceutical company Lilly just put down $8.5 billion or something to buy the compound or something, or the rights to.
Yeah, we're actually going to be seeing, it's predicted. We'll see, these things can change really fast, right?
Correct.
But the prediction is by the end of this year, or certainly during the 2027 year and probably first half, we may see as many as 4 different psychedelics approved across a spectrum. A new form of ketamine approved, LSD approved, psilocybin approved, MDMA approved.
Amazing.
And now there's actually a new form of DMT that is also close to FDA approval. And a lot of that has to do with speeding up the process of, it doesn't mean that they're going around or circumventing good science and good research.
Right.
It's just that the process is speeding up a little bit. These drugs, of course, in our standard Western medicine way of studying and approving drugs, are difficult to create studies for, because the gold standard is a placebo-controlled trial. And that's easy to do with something like Prozac, right?
Right.
But you kind of know if you're in the placebo group if it's psilocybin.
Right. Yeah.
Yeah. So it's hard to do a blind trial with patients with these drugs.
Right. What are some of the biggest misconceptions you can think of about psychedelic assisted therapy? that you're hearing
Um,
out there?
I think the biggest misconception are, probably come from two groups of people. One, groups of people that are familiar with these drugs in a recreational setting, right?
Right.
That you start talking about ketamine, and they're kind of like eyes roll and like, oh, that's a party drug, right?
Right.
Or I've used ketamine, and there's no way that it made me that I could see this as a treatment for depression. You're just getting people, quote unquote, high, right?
Right. Right. Right.
Which again is not the case, right?
Right.
Because when we think about how these drugs work, they're really just kind of a gateway. It's not the drugs themselves, I tell
Right.
patients, that are the treatment. Because if somebody needed to be on a steady bloodstream of ketamine or psilocybin or LSD,
Right.
these medications wouldn't be functional, right?
Right.
The medications, it's all about creating a safe environment to administer the medicines at a very controlled dose.
Right.
And the real treatment actually comes after the medications have done their job, and that
Yes.
glutamate burst, that neuroplasticity, that those changes in the default motor network that I'm talking about, like the
Right.
real treatment comes after the
Right.
experience.
Right. No, and I think that's so important. And just to like stress that too, as someone who in my youth and before I got sober really abused stimulants and really abused alcohol. The last treatment you would think I would be up for, but my addictionologist therapist recommended for my wife and I when we were going through some couples work where there was a lot of trauma, was she was like, we're going to find somebody to help maybe do some MDMA, do an intensive with you guys for a weekend, but also pulling in a psychedelic like MDMA, because what it will allow, and she couldn't really get into all the science behind it, but what it will allow us to do is pull down those walls of trauma immediately, pretty much. So you're
Hmm.
able to do this work that you, and when I say that, it's not because I'm rolling my face off. It's not what's going to
Right.
happen. You know what I mean?
No, you are working hard in those
Right.
sessions, and it's not like you're, on like a large amount of alcohol where you're saying things and you're not really in control and you're
Right.
not
Right.
remembering what happened.
Right.
You were there, but
Right.
the psychedelics just create a a s- a sense in the brain that it feels just so much safer to access
Right.
these parts of ourselves,
Right.
because we bring down some of those emotional barriers. And psychedelics are really good at, and this is another scary part, I think, for patients engaging in this therapy. It certainly was for me during our training, is that they will bring out what's called the shadow self in Jungian psychiatry, like these things that we just like push off into the shadows, right?
Right.
I don't want to think about this. So what might emerge? And I hear that a lot too from patients who have never experienced these substances, is that they're concerned, well, what if I've repressed something since the age of 5, and maybe I don't
Right.
want to, maybe I don't want that brought up, right?
Right.
Maybe I don't want to bring that out. I'm worried what might come up during the session.
Well, and I was working with some of these kids who survived some of these atrocious mass shootings in their schools, and one or two of them I know were doing a study at Yale, I think using psychedelics to really dive into some of the trauma stuff that they've most likely, just pushed down. I mean, it's interesting. I wish in a way, all the relatives that I had who survived the Holocaust and never dealt with that trauma. I think of like what psychedelics could have done for them and their healing and lives. Cause I just
Yeah.
always think about, all my aunts and how they just really were able to push all of that down their whole life. You know what I mean?
Yeah.
Um,
Yeah, like forced to push that down. I think about that all the time. I think about my own brother who died of an
yeah,
overdose, and so many patients that I've lost and friends that I've lost along
right,
the way to substance
right,
abuse or suicide. And
right.
man, if I had a time machine, um, maybe things could have
Should
been
have
different.
totally. I'm a very loud advocate of, and I say this to also people in the treatment field or anybody that are naysayers, is walk in my shoes and let me know how that goes. You know what I mean? And my belief is, if I don't believe and I only try to work with programs too where it's not this cookie cutter mold. I don't believe that we are doing anything for any child or any adult if we are pushing a modality, a medication, something that we just feel safe with, but isn't working, and I do believe that more and more of these treatments are even going to be put into the treatment setting, treatment world. I know in mental health, they're definitely doing it, but, I think even there's more and more work around addiction treatment using these medications. And I think, I guess it's like how those people used to be about antidepressants back in the day. I think that's what's happening is people are just scared and judging, but even and maybe you could tell us a little bit more about, because I don't understand the ibogaine thing, because I know President Trump is trying to push that forward with getting some clearance on that for troops and things like that of that trauma. I don't know enough about ibogaine, but
ibogaine is like this wonderful, can be wonderful, really challenging experience for many patients. It just because of the intensity and how prolonged it is, and especially a lot of the physical symptoms that come up. There are, quite often physical symptoms that come up with psychedelics. And one of the interesting things is that we take a very different approach with these drugs than we do with traditional psychedelics. If I place somebody on a typical prescription, like say a Prozac or a Zoloft, and they're vomiting, right? That's seen as a negative side effect, and we either try and treat the negative side effect with other drugs or remove the offending agent. In these situations, it's almost promoted to explore like what the body is trying to expel, so it's not seen as this side effect that needs intervention, right? That I need to, because you're, vomiting, I need to step in and save you. Like, no, the body knows what it needs to do, and I need to be there to support you. I might have shared this with you last time, but the best way I can describe providing what it's like to provide therapy or care for these patients, the closest thing that I experienced was my rotation in childbirth. Is that you're just letting and trying to let this natural process happen, and you're really just there to support. You're not there to intervene unless you have to.
Right.
But ibogaine is another one of these psychoactive or psychedelic drugs that can provide all those benefits like we were talking about.
Right. And then I guess in all different levels of psychedelic treatment, like who would be a good candidate, you would think, for someone to start to explore psilocybin therapy or anything like that? Who would be a good candidate for you think?
So when I think about it, I think about psychedelic treatment versus psychedelic therapy.
Okay.
Psychedelic treatment, right? For me in my clinic, the folks that are going to fit that best have to fit a pretty narrow diagnostic window right now. In order to get FDA approval, because the medication is very expensive. So they have to have severe treatment-resistant depression or major depressive disorder with acute suicidal ideation. And then I'm looking to rule out things like intracerebral hemorrhage, history of any like aneurysmal vascular diseases, things that would be problematic when we are taking some of these medications that will acutely raise both intracranial pressure and because blood pressure raises.
Right.
Also, respiratory depression that can happen with things like ketamine and any pre-existing breathing problems. And then I'm looking out for things like bipolar 1 or schizophrenia, anything with like a psychotic kind of symptom attached to it. Those are patients that we typically or will kind of avoid administering psychedelics to. The bipolar 2 category is interesting because there was a lot of fear at first about treating folks with a label of bipolar 2. But now many of these drugs are looking for indications for bipolar 2, and what we're seeing overall is that these are safe for that population.
Okay. And then, so that's a good, and I told Jonathan I may ask him a question about this just simply because, and I will be talking about this on a new solo episode of mine, as well as I'm very fortunate in the future. Due to my own personal journey, I got connected to this amazing woman named Dr. Carly Snyder, who's one of few reproductive psychiatrists in the world, really. And she basically is a study of the reproductive cycle and all the mental health conditions that go with it. And so why I say all this is, like many of you out there who are probably have very strong opinions, my heart breaks for this whole Lindsay Clancy case, story behind it, hearing about how many providers she saw, how many medications she was put on. But as I'm talking to you, because I'm thinking, would psychedelics be something that could have been a help to this woman? You're saying if there's any chance of any sort of psychosis or that wouldn't have been she wouldn't have been a good possible candidate.
Yeah, no, I mean, there are folks that are psychotic with their depression, and that's a different category, right?
Okay.
So it's not that doesn't necessarily leave them out. Postpartum depression is interesting. It might be a very close cousin to a bipolar illness that is kind of brought on for the first time with some patients. Because of all these hormonal shifts that are happening during pregnancy and birth and afterwards, right?
Right.
I don't know much about this case. I have to be honest. I think I've seen a couple headlines because they're everywhere. So it's hard for me to kind of give an opinion. I'd have to, know more. But as far as psychedelics in general for postpartum depression, they are researching drugs like psilocybin and seeing enough promise to keep that research going. And if they work in the same manner as like for the population with treatment-resistant depression or major depressive disorder, then my expectation is that we would see a lot of success. Kind of overall, what we're seeing is about a 70% success rate or more with the populations that I'm speaking of. And again, this is a population that would have about maybe a 12%, 15% success rate if they continued on traditional oral antidepressants, right? And so to get that jump, right, is massive. It's life-changing for so many of my patients.
Right.
And I hope that we see that with these other categories, not just postpartum depression, but eating disorders, right? Substance use disorders, which we're looking for indications for a lot of these new psychedelics that can be very powerful and very helpful. OCD, the list kind of goes on and on.
Yeah, and I think, and again, I know you don't know enough about the story. I think why, without getting into all of it, what's kind of upsetting, it's very tragic. It was about a woman who was never diagnosed for any sort of postpartum whatsoever. And she actually did struggle with postpartum psychosis and unfortunately killed all 3 of her children. And I think as a patient, is also a professional, the most frustrating thing I have still found in mental health, just like I guess physical health too, is for me to, and we can talk about this, for me to access or even get a conversation going about ketamine treatment or psychedelic treatment, I have to be the one discussing and bringing this up to my prescriber most of the time. And with that, there sometimes can be shame involved and, or they don't have enough. It's kind of like, and I hate saying this, is like I went to a million gynecologists before, I found one who actually understood that, we're going to treat you and not the number, and that you're not crazy. You're just going through some, you're sensitive to hormonal changes and you have this condition called PMDD, most, I think what would help too with mental health care, physical care, but definitely mental health care, if there was this constant retraining of these professionals, so they're aware of the benefits of these types of medicine, and that it shouldn't take your patient having to inquire about it for it to be discussed.
Yeah, and there's going to be a lot of, I think, lag time between, as there is with any medication, but I think especially a longer lag time with the psychedelic treatments, just to maybe inherent bias from providers that are licensed to prescribe these medications, and knowing that probably the most, like the target audience that is seeking this information out is mostly going to be in the, psychiatry realm, therapy realm. But our number one prescribers of antidepressants are our primary care providers. And the other thing too is that the way that these medicines are being set up and the safeguards is that they're going to require a lot of time and space from that provider. to administer and monitor patients who are taking these medications in the office. And our current medical offices aren't set up for that type of care. They're set up for quick turnaround, one patient at a time, not spending hours with a patient or with patients in a group treatment setting.
Right.
And then we have the problem with reimbursement is getting our insurance companies to understand this bill, how do we bill for, if my time is being used for, 8 hours with some of these medications, how is that feasible financially for the patient and the provider?
I think I'm not expecting these providers to actually do it themselves. I think what would be really great is if they were educated about this to also start the conversation, but then had trusted providers they could refer to and happily do that.
Yes.
And recognize that this way isn't working. I mean, as I say to, and this is just how I feel, but like I was talking to this young man the other day who said he was scared about doing this infusion. And I go, well, for me, what's scarier, and I got to be honest, was always trying a new antidepressant, because I was so sensitive that when I would try one that was bad, oh boy, did we see black box. I had all these horrible, horrible symptoms right out the gate. And that to me was scarier. Or there was a period of my life where I was literally, all these prescribers were just bouncing one antidepressant after the next, and my system in a very short period of time. That was scary to me. I think, or, being a candidate for electroshock therapy, that was kind of scary, but I feel like, these are exciting times, ladies and gentlemen. I think where we are today with science, and I feel that, unfortunately, I wish we had other people in office who were on board with this kind of stuff. But I really feel that as somebody who has struggled, especially when you were asking someone to wait those 4 to 6 weeks with anything, it's a really, really, really long time, especially when you're suffering,
Yes, correct.
And can you just explain, though, psychedelic assisted therapy or treatment, and you compare it to ketamine treatment? Like when I do my infusion, when I am done, maybe 45 minutes later, I am back at work. I cannot drive, but I am back at work, clear as can be. Do you notice any differences between the treatment, if there are any?
Like the different psychedelics?
Well, we said ketamine is a psychedelic, right?
Well, yeah, and it's a dissociative,
I guess compared to
like it counts as a
psilocybin.
psychedelic. Yeah. So psilocybin, when we're taking a macro dose, right? We're talking grams of psilocybin, and it can change from mushroom strain to mushroom strain because they can be very different in terms of their potency, right?
Right.
But when we're talking about that type of treatment, you're looking at sometimes as little as 4, sometimes as much as 8 hours of needing to be held in a safe container. And afterwards, I have not met a patient who felt like ready to go back to work. They definitely needed the rest of the day at least. And then we recommend that there's time off afterwards.
Correct.
Right, yeah. Often meeting up the following day just to integrate the experience that happened the previous day with the medication. With ketamine, most of my patients with the intranasal form of S-ketamine, which is really more psycholytic, like it's not full psychedelic. Do patients have profound experiences? Absolutely, right? But with that medication, most of my patients feel fully recovered and like ready to go at the 90-minute mark. They have to be under my observation for 2 hours at least, minimum. But many of my patients do go back to work as long as their work doesn't involve, heavy machinery or, a tremendous, like I'm not sending my surgeons back into the operating room after treatment, right?
No.
Even though they feel fine, right?
Right.
And the nice thing too is that when we're talking about side effects or negative experiences, you're not talking, you're talking a matter of hours. Especially with ketamine, it's kind of in and out of your system.
Very
right?
much so.
and the dosing control, right? No one's ever going to end up in a K-hole or having those really negative experiences with ketamine if it's being dosed
Administered.
and administered in the proper setting, right? It's just not possible.
Right.
The IV is nice because it's so controllable, right? Whereas forms like intramuscular, it's like jumping into the deep end of the pool. Like, I'm going to put this dose in you and there's no takebacks. And for some patients that works. And for some patients that control with the IV or being able to add in like anti-nausea medicine or anti-anxiety medicines while the ketamine is going in or the experience is happening can be really, really helpful. And then, of course, the S-ketamine that I'm using is intranasal. And there was... like in terms of like the experience, there's this little rhyme that's used in the psychedelic space where it says, if I remember correctly, ketamine is like a trip to space, psilocybin is a punch in the face, and MDMA is a warm embrace. And that's a pretty good describer, I think, of the effects overall.
Thinking of ideas for merch, J-Lo, and I think that's a t-shirt right there.
That's a t-shirt right there.
I mean, I was saying to Becky Gadula the other day on my podcast that I wanted my merch line to be whoever has the pesos has the say-sos, but I hear that's taken. So I think I'm going to replace it with that. My big question too is, I think with everybody listening and wanting to be a resource for everybody is I feel that, you can go online, you can, when looking for Spravato or ketamine infusions, there's plenty of websites out there. You're looking for people, the about page where there are medical professionals administering this in a safe environment. That's pretty accessible, I find. If there's people out there want to look into psilocybin or other psychedelics, can you give them any recommendations of where to go to safely be able to find this treatment?
Yeah, there's a couple hubs that I think of off the top of my head, and not for locating treatment centers. This first one exactly, but when it comes to just kind of an understanding of what's happening in the psychedelic realm, there's a website called psychedelicalpha.com. And they have a wonderful bullseye chart that will show everybody kind of where in the pipeline and what indication are these medications. And how close are they to FDA approval, right?
Yeah, because they're not legal right now, right? Or are they?
So for psilocybin, right, we have legal clinical use in Oregon and Colorado, but it's still not FDA legal. Almost, same thing like with cannabis, where it's legal for even recreational purposes in some states, but that started off with medical use and medical cards, right? But as far as other good sites just for general knowledge. Another one that I like is Spirit Pharmacist. It's run by a pharmacist with a deep understanding and wonderful accessible information for patients to understand how their medications might need to be altered, if at all, because there's a lot of misconceptions out there about what can and can't be taken with these psychedelics. And I find that website is a great resource. As far as treatment, right, like accessible treatment, folks like the Wounded Warriors Project that have been around a long time and are still having to kind of plan trips outside of the country. Costa Rica, I just had a patient come back from Costa Rica for an Ibogaine experience, but that's a huge cost, right? One thing to look for if you are trying to explore this prior to FDA approval, the one loophole that exists are seminaries, church groups, right? Organizations that have formed to get around the FDA kind of blockade of psilocybin. And many of us probably have these near or even in our communities and don't even know it. And these will be organizations that form a nonprofit, spiritual religious organization, and then a part of their practice is to use psilocybin in ceremony. And so then they're able to provide these services or these medicines, but they,
Right.
of course, can't call it medicine. They can't call it treatment. They're not going to diagnose you. So you still need to be
Right.
working either with a therapist or a medical provider that understands these things. But they do give us, I think, a safer pathway to access things.
Like people are working with dharmas, right? Or to be able
yeah.
to.
Yeah, or like there's also like near us in Nevada, there are sometimes you can find certain tribes and on reservation tribal land where they will provide this service. Some do,
Wow.
some don't to outsiders, right?
Right.
And so there are ways, right? But if for somebody who's just looking to start to explore this realm, the reason I like the exploration to start with ketamine is, again, it can be so controlled.
Very
It
controlled.
is, if you meet criteria, approved by insurance. So
Yes, it is.
my Medicaid patients pay $0 for their treatment.
I'm
right?
covered for the infusions. I don't have to pay. So
That's awesome. Yeah, right. And
yeah,
so
go me.
Yeah, go you, right?
Go me. Woo! Treatment
Uh,
resistant depression. Try 1 million meds and you get approved.
Yeah, and you
Yeah.
get approved. And so, and because of the short length of time, I think it's a good introduction. It is a very different experience, of course, to something like psilocybin or traditional psychedelics, but it at least can give patients a way to kind of comfortably enter
Dip their toe in this.
you dip their toe in. And again, with a drug that is just so safe. I mean, ketamine is a medication that we give to, infants when we can't give them Tylenol, right?
Thank you.
This is a medication that is, again, just proven time and time again to be safe. Where it gets a bad rap is when people are abusing it. I mean, you could abuse anything, right?
Thank you.
And
That's
ketamine's
what
no
I
different.
said when that whole story, which was really tragic, about Matthew Perry came out. I remember my initial reaction was, shit. Pardon my French, but I was like, shit. Now everyone's going to say, told you so with the ketamine and da-da-da-da-da. And my thing was, and I immediately said, yeah, and Michael Jackson abused propofol, but we're still using it for surgery. If used under the gut, and anybody can abuse anything. Unfortunately, when you have that much power and money, you can find the right doctor that's going to give you vials and vials of ketamine. And that's what happened to him. You know what I mean?
Yes.
And he wasn't under a doctor's supervision.
No. It wasn't under any supervision.
It was under
he
his
was left alone
assistant.
in a hot tub. Yeah, but
Yeah.
his assistant had walked away.
Right.
It was tragic. Yeah.
But again, anything can be abused. And my whole thing is, I still think alcohol is one of the most dangerous things out there. And that's legal.
Imagine if we were trying to get FDA approval for alcohol, starting today. And we were like,
Right.
hey, listen, we've got this drug. It makes you black out. It makes you not able to drive. It makes you angry.
Right.
It has no medicinal purposes. It's a depressant.
And if you're physically addicted,
what do you think?
it will kill you if you just stop cold turkey. But, but go for it.
Yeah, sounds great.
Where do you see psychedelic medicine in the next 5 to 10 years?
I mean, hopefully on the same track that we're seeing now, where we just have more and more options come out. As these options come out, we continue to monitor them very closely just to ensure, safety and that the public feels comfortable, and then just increasing access. Because I live in a really rural community in North Lake Tahoe, right?
Right.
And, so for environments like mine where you don't have a high population, right, and maybe your closest city is going to be Reno or Sacramento, that could be a huge barrier to care.
Huge.
But as we gather more safety data on these medications, hopefully allowing safe at-home treatment for patients, for the right patients, right?
Right.
And so, my hope is over the next 10 years that we see increased access, right? Destigmatization, affordability. And then the other piece is just also understanding them beyond the waiting for the diagnosis to get so bad. So why can't we use these first line, right? Why do we have to go through and fail the trials if we know that this stuff works?
I know. I mean, I put my shit out there, Jonathan. I was just on the phone with my insurance company before because the antidepressant that I was originally put on a couple of years ago, they switched it. My insurance wasn't paying for it. It was a newer drug. And so we did the compounded version of, right? And so finally my doctor's like, let's try your insurance company again and see if they'll pay for it. And again, in their speech, they're like, well, did you try and fail 6 other antidepressants first? I'm like, why do we need to go there? Like, why does it need to be so many? Because people are just suffering.
Well, they're suffering, and these
and
are
I guess,
life-threatening illnesses. And, like, I
right.
want the same respect. Not that other areas of medicine do much better. Like, there's always, but I don't
But
think
we
to the
should be having,
extent, right?
thank
The
you.
extent that we have to struggle with these symptoms in mental health and the length of
Correct.
time that we need to fail, which is sometimes months or years, would be
Right.
an absolute, like, it would be ridiculous in other areas of medicine.
Or I was told by insurance companies in the past, you weren't depressed enough. Like, who
Right.
tells me? Like, and I remember writing back to that insurance company going, that's like me breaking my ankle. And you're saying, well, you didn't really break it enough.
You didn't break it hard enough,
So,
right? You got to shatter it a little bit more.
It's absolutely craziness. When I always preach that if we're going to talk about the war on mental health, the first thing we need to do is work on those insurance companies. Last but not least, Jonathan Lowe, if you are talking to somebody on the phone, a candidate for psychedelic treatment, what would be some last parting words you would like to give them that you would like them to hear if there is some fear or resistance to doing something like this?
Well, first, I always say that the fear and resistance is normal. Like, even for
Totally.
myself in my psychedelic training, part of the psychedelic training community promotes not just learning how to provide the care, but being the patient as well. And I felt
Right.
so uncomfortable with that. It took me months and months of talking it out to try and wrap my head around why I needed to take these medicines, right? Why I needed
Right.
to take the drugs, right?
Right.
And so know that fear and that resistance is normal, and part of it has to do with just how your brain works, right? Our brains on a neurological level don't really care about our happiness. It cares about survival. And some of
Right.
us have been surviving with depression for a very long time. And
Right.
so walking into a therapist's office, trying any new medication, my expectation is that there's automatic resistance from the brain, because basically you have a brain that says, hey, being as depressed as we are, 100% survival rates. And now you're trying to mess with 100% survival rates, even though logically you don't like the way you feel. The brain doesn't really care.
Right.
And so it's just understanding that you are not depressed, right? Your brain is depressed. The organ is depressed. You are not, you don't have depression, right? Your brain has this symptom. I'm always careful to help my patients not to identify with their mental illnesses, because we don't do that with any other organ illness. We don't walk into our doctor's office and say,
Jonathan.
I am stomach ache, I am broken ankle, I am, whatever. We don't say that, but we all the time we say, I am anxious, I am depressed. That's just an organ, right? And the resistance comes from that
knowledge without even trying.
Drop in knowledge, right? It's just that organ trying to protect you in the ways that it knows how, and it only knows that you're alive today based on all of your experiences, which is why these changes are so hard to make. And then sitting with a provider, again, just making sure that they take the time and that they're not pressuring you, right? That they're pointing you in the right direction, giving you the education you feel you need, but also at the same time challenging your depression, right? I don't want to see my patient's depression making the decision not to engage in treatment. I want to challenge that. Just same thing with addiction, right? I don't want to let my patient's addictive disorder make the decisions for them, because I don't think it's making good decisions on their behalf. I trust my patients. I don't trust their addiction. I trust my patients. I don't trust their depression. And helping them to kind of separate consciously from that process. And then, it's normal to go in with skepticism, hesitancy, especially after we've been burned so many times. If we are a treatment resistant patient, you're not walking in hopeful, right? Like, hey, I've tried all the things I've been told to try and nothing's worked. Why this? Right?
Don't be like me, who just believed all the I believed my fear about the ketamine. So I was like, yeah, I'm going to do ECT first. Let's try that bad boy, because I thought that was the safer, easier route. Not saying it's bad for some people. Sometimes it's very effective.
Yeah.
But I encourage people before they are just so quick to say no is to do your due diligence and really, read about and study or look up, some of these treatments before. Because a lot of times when I do get this like false narrative coming back at me about all this stuff, it's based on nothing but their fear. Like nothing, nobody's, you know what I mean? So I do encourage that because I do see how psychedelics are saving people's lives today. And really, I'm for it.
Yeah, and on the flip side, working with people that aren't just all gung-ho and positive about it too, right? Like you want a provider that is telling you, here's the what we know that's good, and here's what we know that could potentially be negative, right? It shouldn't all be like, just like almost evangelical selling of psychedelics, right?
No.
These and like for my substance use population, I often will refer them to online psychedelics and recovery groups, which are growing in number.
Great.
So an alternative to maybe their AA or NA space to help them be in an environment that is comfortable and supportive so they can at least ask the questions and feel comfortable asking the questions.
Right. Because I first started learning about psychedelics from men and women who had like over 30 years of sobriety, and it was just like on the DL. They just don't talk about it. We're not supposed to talk about it. And so there's this like, you're already feeling this shame already, and then you're told not to talk about it. So that's really great information too. And again, Jonathan, I'm just, so grateful that you came back on the show. You are going to be probably a repeat offender here on Connect Call, I hope.
That would be great.
You are a wealth of knowledge, and I really appreciate you. This is another episode of Connect Call. Please tune in every week on Thursday. Make sure you go to your Spotify, Apple Podcasts, and YouTube to subscribe and check us out. And we look forward to another episode coming soon. Thank you. Thank you for tuning into this episode of Connect Call. As we conclude, remember that insights shared are intended for informational and educational purposes only and should not substitute professional medical advice, diagnosis, or treatment. We strongly recommend consulting a qualified medical health professional or healthcare provider for personalized advice tailored to your unique needs. Your mental health journey is important, and having the right support is essential. If you're experiencing a mental health crisis or require immediate assistance, please reach out to a mental health provider or emergency services in your area. We're grateful to have you as part of our community, and your well-being remains our priority. So follow us on social media to stay connected, and be sure to catch one of our episodes on our YouTube channel. We're here to support you every step of the way.